Hi everyone. My name is Alyssa Snow. I'm an international student that just started here at WVU in May. So, to give you an idea on my social work perspective and lens, I'm from Cape Breton Island. It's in Nova Scotia, which is on Canada's east coast. Today, I'll be presenting on cultural safety and substance use treatment for Indigenous mothers involved in the child welfare system. And I'll be making some comparisons to rural Appalachia, particularly that of West Virginia. So, my professional background is in supporting women and children fleeing intimate partner violence. It's work that often intersects with addiction, trauma, and child welfare involvement. I chose this topic after realizing that the history of residential schools, widely discussed in Canada, is also part of the US history through Indian boarding schools, though, at least through our course discussions, it often seems less visible here. In Canada, Indigenous peoples make up about 5% of the population, many living on reserves, while in the US, they are about 2.9% and often more dispersed. So, from my presentation today, I'm really hoping to sink in these four key points. I want, first of all, to do an overview of addiction among Indigenous mothers within the context of child welfare and policy. Second, the importance of cultural safety and treatment, which describes the systemic challenges that perpetuate disparities, which are deeply linked to historical and social determinants. The third, you should know that I'm going to focus on Canada, but I'm also comparing it to rural Appalachian West Virginia context. And finally, the critical relevance to substance use treatment for culturally competent social work. So it is important to recognize that Indigenous mothers involved with substance use face complex challenges tied to historical, social, and systemic factors. These challenges are further complicated by the child welfare system, which disproportionately impacts Indigenous families. Cultural safety, meaning care that respects and incorporates Indigenous culture and worldview, is crucial in treatment but often lacking. By exploring the issue from a Canadian perspective and comparing it to rural Appalachia, I hope to highlight common barriers and potential solutions that could improve outcomes for these vulnerable populations. Understanding the present requires looking at the past. For over a century, Indigenous children in Canada were forcibly removed from their families and placed in residential schools. These schools aim to assimilate Indigenous peoples by erasing their language, culture, and family connections. Many children experience physical, emotion, and sexual abuse. As detailed in the Matheson article in the Truth and Reconciliation Commission, the trauma from residential schools has deeply impacted Indigenous families and communities. This trauma is intergenerational. The Braveheart article illustrates how this historical trauma is linked to substance abuse as a coping mechanism. Empirical evidence from the Turner article shows that residential school attendance across generations increases the risk of substance use. So, fallen residential schools, the 60s scoop, so by the hands of social workers in Canada, who further removed Indigenous children from their homes into foster care and adoption, severed cultural ties even more. Despite these traumatic histories ending only recently, residential schools closed as late as 1996 in Canada. The involvement of Indigenous children in the child welfare system today remains higher than ever before, reflecting ongoing systemic inequalities. As learned in the Barnett article and the Matheson article, for Canada, Indigenous women are 2 to 3 times more likely than non Indigenous women to experience a substance use disorder, often linked to trauma and systemic inequities. Studies show, especially that of the Ontario Health, that lifetime prevalence of substance use disorders among Indigenous women is between 17 and 30%, and current opioid use is reported by 19% of Indigenous adults compared to 13% of non Indigenous adults. Substance use is also a frequent driver in child welfare involvement for Indigenous mothers, often leading to family separation, as we learned in the Schmidt article. Looking at Appalachia, specifically West Virginia, the opioid crisis has had a devastating impact. About 18% of children in West Virginia are affected by opioid use, which equates to 50 per 1,000 children needing services. The state spends an estimated $4 billion annually on programs addressing the consequences of opioid use, including child welfare and foster care costs, as learned through the article through West Virginia Perinatal Partnership. Here we see stark child welfare disparities. Indigenous children represent only about 7.7% of the Canadian population for those under 15, but constitute 53.8% of children in foster care nationwide. In Nunavut, for example, approximately 90% of children in foster care are Inuit, even though Inuit make up about 85% of the population, showing clear overrepresentation. According to Statistics Canada in 2024 and the Vanier Institute of 2024, First Nations children are removed at a rate of roughly 41 per 1,000 and Inuit children at 33 per 1,000, both rates far exceeding those for non-Indigenous children, so 17 times higher than that of non-Indigenous children. 50% of First Nations parents have active child protection involvement compared to 13% of non-First Nation parents, as we learned in the BMC Public Health of 2025. And substance use is often cited in removals without addressing root causes such as trauma, poverty, and systemic racism, as learned in the Schmidt article. So certainly this overrepresentation reflects system inequities and highlights that substance use cited in these cases often mask deeper social and historical trauma. Looking closer at biological factors, intergenerational trauma affects brain chemistry and stress responses, increasing vulnerability to substance use disorders. This is detailed by Matheson's article, who describes neurobiological pathways linking colonial trauma to addiction risk. Additionally, many Indigenous mothers face co occurring medical conditions compounded by a lack of accessible health care, particularly in rural and remote areas. Substance use during pregnancy poses significant biological risks, including neonatal abstinence syndrome. Similar challenges exist in Appalachia, where opioid addiction and rural healthcare shortages limit early intervention, as noted by the West Virginia Perinatal Partnership. Psychologically, trauma manifests as high rates of depression, anxiety, and PTSD, often leading to self medication with substances. This is explored by Schmidt, who examines how stigma and trauma hinder treatment engagement. Loss of cultural identity and disrupted family connections contributes to feelings of isolation and low motivation for seeking help. So parenting confidence suffers when role models and support system are missing, which was a theme discussed by the Barnett article. Similar trauma-related psychological barriers are documented in Appalachia, where economic hardship and overdose deaths contribute to mental health struggles and addiction stigma. Socially, Indigenous mothers face systemic barriers such as rural isolation, poverty, and limited infrastructure. Many communities lack clean running water and adequate healthcare facilities. As many of you know, in Canada, healthcare is free. For Indigenous persons, they have a specific program called the Non-Insured Health Benefits Program, but this further complicates access to care due to jurisdictional and funding issues. These barriers are detailed in the Pollitt article. Systemic racism in healthcare and child welfare perpetuates distrust and stigma, which leads to further service avoidance and higher child removal rates, and this is described in the Fairmont article. Appalachian populations experience comparable rural poverty, poor healthcare access, and addiction stigma. One promising framework for addressing substance use among Indigenous mothers is the concept of two-eyed seeing, developed by Mi'kmaq elder Albert Marshall. Two-eyed seeing means learning to see from one eye with the strengths of Indigenous knowledge and ways of knowing, and from the other eye with the strengths of Western knowledge and using both together for the benefit of all, as we learned in the Marsh article. In the addiction treatment context, the Indigenous eye might include traditional healing ceremonies, elders' guidance, land-based activities, and community storytelling circles. These approaches emphasize holistic wellness, addressing mental, physical, emotional, and spiritual health, and reinforcing cultural identity, which can be a protective factor against relapse. The Western eye incorporates evidence-based medical and psychological therapies. These include medication-assisted treatment, such as methadone, buprenorphine, or naltrexone for opioid use. For cognitive behavioral therapy and dialectical behavioral therapy to address thought patterns, coping skills, and emotional regulation. motivational interviewing to strengthen treatment engagement, and harm reduction services like needle exchange programs and supervised consumption sites. Research shows that when the trauma-informed and family-inclusive approaches are blended with two-eyed seeing, retention and treatment improves, relapse rates drop, and trust in services increases. This is supported by both the Marsh article as well as the Van Warmer and Davis textbook. On this policy side, in Canada, Jordan's principle ensures First Nations children have equitable access to health and social services without jurisdictional disputes, but significant gaps remain for Indigenous mothers themselves, as learned in the Blackstock article. In Appalachia, while there are innovative opioid treatment programs and harm reduction initiative, rural areas still face underfunding and patchy service coverage in the ERP article. Both regions could benefit from sharing strategies, particularly how to better integrate cultural safety into mainstream treatment of addiction. Despite the evidence supporting effective culturally safe treatment approaches, many Indigenous communities lack access to well-funded programs under community control. Addiction policies often criminalize affected mothers, increasing stigma and child welfare removals. Child welfare policies tend to emphasize separation rather than family preservation, which perpetuates trauma and substance use. These systemic gaps are mirrored in Appalachia, highlighting the urgent need for policy reform, increased resources, and community-led programs, as described in the Blackstock and Schmidt article. Moving forward, it is critical that Indigenous communities lead the design and delivery of culturally safe, trauma-informed addiction treatment programs as advocated in the Marsh article. Family-centered treatment that includes parenting support and coordination with child welfare services can improve outcomes and support family preservation, especially as recommended in the Bartlett article. Harm reduction services must be expanded, and punitive policies limiting access to treatment for pregnant and parenting mothers should be reformed, especially as argued by the Schmidt and Blackstock articles. Healthcare and social service providers require training in cultural safety and trauma-informed care to reduce stigma and build trust, a need that was certainly underscored in the Fairmont article. Investment in rural health infrastructure, including telehealth, can reduce barriers to care, especially shown in the Thompson and Paulette article. Finally, cross-jurisdictional collaboration between Canadian Appalachian health systems could foster shared learning and innovative solutions, addressing similar challenges seen in the West Virginia Perinatal Partnership Study. So in conclusion, addiction among Indigenous mothers involved in child welfare is deeply rooted in historical trauma, systemic inequities, and ongoing social challenges. Culturally safe, community-driven treatment and policy forms are essential to break cycles of trauma and support family preservation. Lessons from rural Appalachia highlight common challenges and opportunities for shared solutions. Ultimately, a holistic approach that respects Indigenous knowledge, prioritizes healing, and reforms systems can improve outcomes for Indigenous mothers and their children. Thank you kindly for listening to my presentation. I look forward to any feedback and questions that you may have. On this slide here, I've attached the 8 core references that I read and utilized for the development of this presentation. This slide is references that were specific to historical context and intergenerational trauma. This slide is references specifically to rural health inequities and barriers to care. This slide is references specific to stigma, oppression, and child welfare system involvement. This slide is specific to references that address substance use treatment for mothers. On this slide, the references are specific to integrating Indigenous and Western healing approaches, the U.S. and Appalachian context, as well as our course textbook. And finally, this slide is references specific to racism, policy, and social justice and addiction. Thank you again for listening to my presentation.